going to be a discussion between Moira Griffiths-Parr and research nurse Jane Tinsley. So Moira and Jane, can I hand over to you, please?
Thank you. So as we've just said, so we're going to do a journey through CLL, and really this is Moira's journey through CLL. So my job as a research nurse is to kind of guide people through a trial, to act as a kind of point of contact, to help support people through that study, really, but also to act as support outside the trial, I would say, as well, and try and help with anything else that kind of crops up along the way, really. So I've done this job, certainly been a research nurse since about 2009, and since 2017, my role has been more about supporting a whole team of research nurses. So I still do some hands-on work, which is great, and which is what I really love to do, and I don't want to get away from. And my background's been CLL lymphoma for a long time now, but I also oversee a team of nurses who cover the whole of haematology, do stem cell, myeloma, acute leukemia, all sorts of different research across the patch really now. So it's nice because I get an overview of everything that goes on. And Moira and I have known each other for a very long time now. And this is really going to be the story of literally Moira's journey through with us, really. So as we've sort of said, so we're going to sort of, obviously we've introduced ourselves. We're going to talk about a timeline. That's kind of when we were chatting about this, we thought that was kind of the best way to do this, is to literally start at the beginning and work our way through to today and what's happened in between, really. And then at the end, there are some questions that Moira has that are good questions for you to ask and go back and ask your clinicians, but then also space for anyone to ask any questions of us that you've got from what comes up now, really. So I will hand over to Moira now to talk about the first slides.
Yeah, so obviously diagnosis. My diagnosis was in 2012. And I originally, as you can probably hear from the accent, and I know there's a few Liverpudlians amongst us, I actually live over the water. You can see over there on the Wirral. And I was diagnosed at Arrow Park Hospital in 2012, and I was diagnosed with SLL, small lymphocytic lymphoma. I have 3 daughters, I have 3 girls, and they weren't very happy with the fact that I was on this horrible word, watch and wait, or as everyone calls it, watch and worry. Can the clinicians amongst you find other words for this? Because I know it scares people very, very much. But anyhow, what we did was we decided that we would go for a second opinion. And between Dr. Dasgupta's secretary, lovely secretary, and himself, it was suggested that I look to the Royal Liverpool Hospital and to look to being treated by Professor Andrew Pettit. Now, those of you who aren't from Liverpool will know now we're at Clatterbridge Cancer Centre, that other beautiful hospital over the road, our wonderful facility that we have there. But initially it was at the Royal, so I'll be talking between the Royal and CCC. And so the second opinion, I went to see Prof. And within that 6-week time it took to get that second opinion, all my lymph nodes had literally doubled in size. They were quite big in my neck, down my neck, under my arms, in my thorax, and one in my groin. So Prof looked at me and he said, "Yep, need treatment. I've got a trial going, and it's called Arctic." So that's how I ended up going on Arctic trial, but with the support, as Jane said, of her role, and that was, Jane's like my 4th daughter. Jane has seen me through, and it's because we are so very, very fortunate at Liverpool CCC that we have so many, and they're sitting over there, some of them, we have so many wonderful nurses who will help guide us through our trials.
It's very kind. Money later.
Yeah, okay.
So, hopefully this jumps forward. Right, so just to talk about Arctic. So at the time, so all trials will have a title like this, and when you first look at this, it looks really confusing, but all you've got to do is kind of break it down into little bits. So really, Arctic, so multi-centre, there's lots of places doing this. randomised control. So randomised control basically means there's more than one option on the study, and the randomisation is controlled. So what that means is we don't get to choose which arm that people get, and we can't say, well, we want you to have this arm or you to have that arm. So all that is done centrally. So it's a bit like a tombola. It's all jumbled up, and then a computer will jump out and say, right, give this person arm A or arm B. So all that's controlled centrally. Phase 2 means that there's different phases of studies, so I don't know how familiar people are. So a phase 1 will be first in human. Phase 2, which this one is all about, we know that a drug works, it's already had some testing done, but really we're looking more about the safety of a drug and the side effects of a drug and how well it works in a particular condition. So it's still quite early stages, but there's already quite a lot of information that supports the use of the drugs that we're using at the time. And then obviously previously untreated is obvious, so no one's had any treatment before for it. Obviously it's for CLL. So within this study, there was 2 different arms. There was the standard FCR, so obviously as we're saying, and obviously from what Stella said before, treatment's moved on a lot now. But back then, chemotherapy was still the go-to, really, wasn't it? And FCR in particular, so fludarabine, cyclophosphamide, rituximab, so this combination of chemoimmunotherapy was the main thing that was used. But in this particular study, there was a theory that you could give a smaller amount of rituximab and still get the same results. So that's the study we went into, and obviously Moira went into. Now, just as a little sidebar, really, so Arctic itself, when people open these studies, obviously they're set up with a really good premise, and there's a lot of science behind them and a lot of ethics behind them when they open. But it's only when you put people into the studies you can really see how they work. And this particular study, it became apparent quite early on that the FCR with the mini-R wasn't really working that well. So everyone was shifted across to FCR anyway in the end. So although it looked like it was initially a good idea, very quickly it changed. There's a team of people that cover safety on studies, and they will meet very regularly and just make sure that things are going as they should. If there's any risk to anyone, sometimes a trial will be shut down. Sometimes people are given the treatment that looks like it's better. So that there's never any danger with any of these things. And this is where we were with Arctic, wasn't it? Absolutely. Okay.
So before you go on to any trial, don't know if any of you have been on any clinical trials, but, you know, there's a lot of paperwork to look at. There's a lot of language that we don't understand. There are a lot of acronyms. And you don't need to worry about that, because having your trials nurse with you, your trials nurse will take you through all the information that you need to have in relation to a clinical trial, and all the good things and all the maybe not so good things that tend to come around. We'll talk about them later. But my first cycle was in August 2012. And I'd just taken my school through academisation. I'd done all the work for it. We were supposed to be an academy on the 1st of September 2012, and I had to have my first chemotherapy on the 30th of August 2012. So there I was off. And I received my reverse trial, as I mentioned before, at Liverpool, the Royal Liverpool Hospital. So, you know, that wasn't too bad. I mean, this was a rituximab, this was an infusion, and 14 tablets to take when you got home. So, you know, doesn't really sound a lot, but it is sort of chemotherapy. And that first cycle was okay, and my bloods were coming up to say, yeah, I was okay. And I loathed Wednesdays for the next month. I felt sorry for my husband going through the tunnel on that Wednesday before the next cycle, because all I wanted to ensure was that my bloods were going to be okay and I could have the second cycle and I could get on with this, you know, because I'm that sort of person. I do have a thing, get in, get on, get out. You know, let's get on with it, let's do it, and let's carry on carpe diem. So we had those monthly cycles, so yeah, great. I was able to go through the second cycle, and then that was okay again. Another Wednesday through the tunnel, will I be all right again? Yeah, perfectly okay, until we got to the 5th cycle, and then we had to stop at the 5th cycle. Mm-hmm. So there were 6 cycles of this FCR, fludarabine, cyclophosphamide, and rituximab. Yep, I can say the names. And so because of the way my bloods were going and the way I wasn't feeling too good, we stopped at number 6. But we did get quite a lot of benefit out of having those 5 cycles. So Jane will tell you why.
So what we wanted to touch on is why there is no cycle 6, and there'll be people in the room that have been through this. There'll be people that only had 3 or 4 cycles of FCR, because you get to a certain point where, as Moira says, within a month the blood count should recover nicely. It should be at a nice safe level to go ahead with the next cycle. But obviously chemotherapy has side effects, and again it's good that we've moved away from that to a certain extent. Because one of those side effects is a potential damage on the good immune system and the good cells that sit within the bone marrow. And within that 4 weekly period, if it's taking longer for things to recover and maybe things haven't quite got back to where they should be, and especially within the trial as well, there was like a couple of weeks grace to give it a bit more time, see if things get back to. But if the bone marrow is starting to struggle, I suppose is the word that we would use a little bit, we'll then say, well, actually, we've done a lot of good with this treatment. We don't want to cause any harm with this treatment, so now's the time to stop. Because we set out to give 6 cycles. 6 cycles is historically what's given and what people think is right. But it isn't right for everybody. So obviously you've got to sort of assess each person as an individual and think, OK, we've done the best we can. We're going to stop now before we potentially cause some harm, which we don't want to do.
Yeah, absolutely. And of course, you know, as I said, all along the way, you don't have to be worried about being on a clinical trial. You're not on your own. You're totally, you've got that support mechanism there. We certainly do have at CCC and what was the Royal, where we have that support mechanism whereby we had any worries, anything at all. You know, I had Jane to be able to talk to, and if Jane wasn't there, I had Darren to be able to talk to as well. So, you know, any of you that are even thinking, or maybe in the future, about clinical trials, you know, do be confident that even though I didn't get onto cycle 6, I still had that support mechanism on the way, and that support mechanism was vital because they didn't want me to be put in a situation whereby things would not be right at all. And then on the 13th of the 3rd, 2013, we actually had a CLL conference in Liverpool the day before that at the Lace Centre in Sefton Park. I got my remission. So that was great. That was great. So my remission was confirmed then.
Okay, so this is the story so far, essentially.
So obviously, I got about 3.5 years out of that trial. Sounds like you've bought something and then the manufacturer's warranty has run out, doesn't it? But yeah, maybe it did. I got 3 years out of that trial, and then I was, you know, still being monitored, and the beauty about that was that I wasn't being left on my own, even though, you know, I'd come out of a clinical trial, you know, I'd had a remission. You know, I was still being monitored. But then, you know, 3 and a bit years later, we started seeing CLL raising its ugly head again. I always call CLL an uninvited guest. You ever had an uninvited guest that knocks at your door? You know, oh, come on in. You know, you make them welcome, but you don't really want them to overstay the welcome. But at the same time, you know, you have to bring it in and you have to say, well, this is my attitude. You have to say, right, okay, you've come back, but don't think you're going to be staying for long. We're going to do something about you. Keep your room tidy. Make sure you put some money in the pot for the food, but you ain't going to hang around for too long.
Oh. It was going so well. Right, let's try and get back to the bottom. Fat fingers. Right, I'll stop there.
So then, because of the way my bloods were looking, Prof suggested there was another. I wanted to go on to another trial. I am a very, very strong believer in clinical trials. I believe that clinical trials are going to be the way forward. They are, you know, less. You know, obviously it's the research and the clinical trials, but I really do believe that clinical trials are going to be the way forward. It might sound a bit of an altruistic approach to it, but you know, that's me. You know, I wanted another clinical trial, and I said to Jane, when it came, Jane, I want another clinical trial. What's around the corner?
Luckily.
And luckily, just can I just say something before that? We had a lovely sister on our ward who became matron, Eddie. Oh. And I might say this again later on, but I always, you know, some people say certain things, and those two little grey cells, as Poirot say, remain in your head. And she said to me, Moira, there is always something new round every corner. And she could not have said a truer thing. So suddenly, there comes clarity.
Okay, so this time, slightly less complicated title this time. So this, basically what Clarity was looking at is combining, so these new treatments, or new at the time treatments, so combining ibrutinib with venetoclax for relapsed refractory CLL. So people that have previously had some treatment and obviously need treatment again. So it's a much more, again, more straightforward title, and so that's what we were looking for.
So this trial has two drugs in it. It had two drugs in it, ibrutinib and venetoclax, and they were introduced. Ibrutinib was introduced first, and then it followed in by venetoclax. So I was put on this drug. Yeah, it was going okay, and then we introduced venetoclax. I'm sure some of you have been on drugs. You have to make sure your kidneys are all right, and they give you another drug for the first one called allopurinol, and that was all okay. And my kidneys were okay, and everything was going all right. And then they introduced venetoclax. And unfortunately, things started to go a bit wrong. My body didn't seem to like what these drugs were doing to me, and the cause and the effect that I was getting, you know, from those two drugs. Now, the thing with clinical trials is, I think we also have to remember, is, yeah, they're going to be great for some people, and maybe sometimes they're not. But the reason why you're monitored and the reason why you are looked after so well is to actually stop anything from going too wrong. So therefore, when we had all these various things that were showing up, obviously in bloods, and obviously my own side effects that came from that, then we stopped the treatment, didn't we?
So we had a little pause.
Yeah, so we stopped the venetoclax, and we carried on.
I think we stopped both.
We stopped both, didn't we? Yeah. So we actually said, you know, as Meatloaf says in his song, stop right there before you go any further. Do you love me? Any of you know Meatloaf? And so we stopped the trial there.
And then we tried to restart, or we did restart venetoclax.
Yeah. So then when we started, my body decided to say, you're not having any platelets. It tried to produce them, and then it just kicked them out again. They were so immature, my platelets. And that's a condition called ITP, immune thrombocytopenia purpura, or immune idiopathic, sometimes as it used to be called, purpura. And basically, my platelets were on the floor. I wasn't well. I ended up in hospital having some IVIG treatment. And we just had to keep on going. And then when we got to the 28th of March, we found out actually there was only MRD, minimum residual disease. There was only minimum residual disease left in the bone marrow, even though I still had the ITP condition. The CLL had gone back to, the guest had gone. He'd been kicked out. The guest had gone, so there was only minimal in the bone marrow, wasn't it?
And the theory, at the time when Clarity was set up, the idea was it was a 2-year treatment. So this is quite early on in the treatment, really. Yeah. We're talking about maybe 6 months in, and already it had worked incredibly well. Yes. It's just that it worked a bit too well in areas that we maybe didn't want it to work in as well, hadn't it? That's right. So this is about the support, isn't it? So at this point, still ongoing. Yeah. We're trying to keep it going for as long as we can with extra support for the platelets, really.
That's right. So in clinical trials, when other things tend to go wrong, then you do have other support mechanisms which will then help support what's going on. So I saw lovely Dr. Martlew, who is a haematologist but works in a different area of haematology. And I was put on a drug called L-Trompopag. And then I had other drugs which went with that as well, cyclosporin, pentamidine, and filgrastim. So it was a bit of a cocktail, really. You'd go for the whiskey, you'd go for the vodka, you'd go for the gin. You'd try to see, which one you got the best outcome from. And I was on L-Trompopag for quite a bit, but this platelet issue still wasn't going away.
And when we just to go over these drugs, I guess, a little bit. So as Moira says, the L-Trompopag is to try and support the platelets. The cyclosporin was trying to do the same, trying to sort of correct things. The pentamidine, the filgrastim, so pentamidine is like the Septrin that was mentioned before. So some of you may or may not have had it. So it's support for making sure you don't get pneumonia, essentially. But it's a breathed-in version rather than tablet version, because the tablet version can affect your platelet count. So we're trying to support in different ways. And the filgrastim is the growth factor that was alluded to before as well, so to try and support other parts of the immune system.
So we stopped venetoclax. Eh?
We
admitted defeat. That's okay. It's okay to admit defeat, because, what's the point in carrying on with something? But as long as you're in conversation, with your nurses, with your clinicians, that's okay. You can get to that point and you can say, well, it's all right, we've got to stop right there before you go any further. And that's what we did. We stopped venetoclax.
But we're still trying to fix the ITP at this point.
But we're still trying to fix it.
Yeah.
So we go along, and poor Prof, he was beside himself wondering what to do with me and this ITP condition. And he said, well, Moira, he said, I think the only other outcome is to have your spleen removed. So, all right, okay. But I had another drug that was injected. After the L-Trompopag, we went on to a drug called romuplistum. And, I'd been going along with that. It's just a subcutaneous injection. And I went to see the lovely anaesthetist on the day. It was the 4th of January. And he said to me, he looked on the screen because I'd had my bloods done. He said, your platelets are quite high. There was something like 100 and odd from being literally, like 20 odd. And I said, I can't believe it. I said, no, that'll just be one day. They'll go down tomorrow. It's me, the great physician. I said, no, they'll go down tomorrow. I said, don't worry about that. And then Prof phoned me in the evening, and he said, I don't think we need to do this, Moira, he said, because I'd had another blood test. And he said, your platelets seem to recover. And on that day, my 5th grandchild was born. So I will always remember that day. It was the 4th of January, 2019. And on that day, my little grandson was born, my youngest grandchild. So I didn't need the spleen taken out, which was absolutely fantastic, because the platelets had just recovered. So even though you might have to go through, additional treatments when you're on clinical trials, it's worthwhile trying everything you can possibly do to get yourself back to ground and to get yourself grounded again, to start feeling better from your CLL.
So just to go over the timeline again. So this is kind of where we are. I'll try not to do it too quick. This is where we are so far. So we've done Arctic, we've done remission, we've followed up Arctic, we've come out of remission, we've done clarity. We've had some issues, which we've obviously discussed, and the ITP and the treatments for this. So we're now at this point now, in between clarity and what happens next.
So in between clarity and going on to the trial, which I'm currently on, I am actually on the trial for acalabrutinib. I know acalabrutinib has been brought in to being dispensed, but I'm actually on that trial. It's called Assure. But I had a lot of immunity issues, a lot of infections. I mean, thank goodness I didn't have that spleen taken out, because what comes knocking at the door in 2019, but it was COVID, wasn't it? you know, and thank goodness I didn't have my spleen taken out. Sadly, I did end up in Arrow Park Hospital with issues to do with infections. And I was 2 weeks in there with COVID in 21. But the CLL started waking up again. That uninvited guest started knocking at the door again. We then had to start looking at trying to not only deal with my immunity issues and my infections, but we then had to start saying, what are we going to do about CLL?
Good, but my slides are stuck. We're stuck now. I don't seem to be able to move forward now, which is slightly disturbing, isn't it? Yeah, might be a result. Should we go to, yeah, we're a bit stuck. It won't move forward after this for some reason. That's true.
Moira said something always comes along.
That's it. It's you, Lewis, in this instance.
What's the case?
Well, there you go. I don't know what you've done. What you've wiggled.
Which one do you want?
That's right. Yeah, the road. Yeah, that's right. Yeah.
Okay.
So it comes back. That's just electronically stuff. It comes back and then CLL starts knocking at the door again. It started knocking at the door when I was actually in hospital with COVID. It started raising its ugly head. Well, actually started a little bit before then. And it started raising its ugly head quite significantly. There are quite significant swollen lymph nodes all over the place. And so then obviously we're going for the discussion with Prof and Jane, and we went on the road to Assure.
So this time, Assure is a different trial again. So phase 3B. So 3B means that the drug's already out, it's applied for licensing, but 3B means they're kind of gathering more data on side effects and things that go in the sheet that you open when you take those drugs and have all the side effects listed. So it's almost at the end really, and we know that it works really well. So again, multi-center even, lots of places doing this. Open label means everyone knows that the trial and us, everyone knows that you're taking the drug. There's no blinding, which is when sometimes people don't know if you're getting a placebo or not. Single arm, it was only one choice with this study, and obviously it's looking at acalabrutinib in people with CLL. So this one, just a little sidebar really, this is what's called a commercial study. The last two we've talked about are what we call investigator-led. So there's a little difference between those in that an investigator-led study will be something where a consultant with a lot of knowledge in an area will want to run a study and will have an idea about comparing different studies. They often come through the specialist groups and they're supported by other consultants and specialists in the UK or abroad. And they'll often seek funding and grant funding for those to kind of be run. With a commercial study, it's a slightly different setup because you've got a drug company who's made a drug. Obviously, they're interested in trying to get as many people as possible interested in using that drug because they obviously, I'm not saying they're not altruistic and they don't want to share that, but they also want to make money. The bottom line is they do want to make money out of this drug. So they're interested in funding a study so that people will try and use it and see if it works. And acalabrutinib is kind of next generation ibrutinib, isn't it? So that's kind of where we're at with trying Assure.
So as I said, you know, it started to raise its ugly head again. And we waited and we waited and we waited for the okay from the commercial company working with CCC and Professor Pettit to get the okay to start the trial. You know, we were going down that path, we were going down that road. You know, at one point, you know, I was, well, shall we, you know, Prof gave me the opportunity of, shall we do something else? I said, no, we're nearly there. We're nearly there. And we actually got there. You know, they had to tick a lot of boxes at CCC because it's a commercial trial. More boxes, I think, than normal you have to tick, didn't you?
That made setup a bit more tricky this time around. It took a long time to kind of get open with this study, didn't it? So we're looking at a year really almost, aren't we, from talking about it to actually getting it open.
Yeah, and of course, you know, we still had COVID in between all of this, didn't we, you know? So eventually, you know, and thank goodness we got the okay, which was brilliant. And I started on, I think you might have all heard of this quite wonderful drug, acalabrutinib. We started with acalabrutinib in March 2021. And just as when I was talking about FCR before, and we moved on, it's 11 years since. It's really funny, isn't it? Because, look back, line of rituximab infusion, 14 tablets, feeling absolute rubbish. This is 2 little tablets, one each 12 hours apart, with plenty of water, 12 hours apart, supported by a prophylactic cover of cotrimoxazole. And there's the difference. And that, it gives you a better, we've moved on so much. And as Eddie said, there is always something new around every corner. And we've moved on for patients like us, having a better life, a better quality of life with some of the drugs that are around. So this drug, 1 little tablet's in my bag there. 1 little tablet twice a day, supported by cotrimoxazole. So I'm on month 26 now at the moment of that trial, and I'm going okay. I get regularly monitored by Jane and Prof. I'm also on an IVIG cover every 28 days, which I go in for an infusion for, but I've had so many infections and my immune system's a bit rubbish. But other than that, I've got quality of life. I did retire in 2014, but, it's enabled me to still be semi-retired. I do educational advisory work, and, going through these things have allowed me to still live my life, even though that uninvited guest still comes knocking at my door. It doesn't stop me, from living my life. So at the moment, we're on month 26 of acalabrutinib.
And that is essentially the story so far. So the next slide is just about questions for people to ask their clinicians, really. So I'm going to bring them all up, because these are things, hopefully not go too far. I'm going to bring them all up because these are the questions that we thought.
I did actually take these questions from CLL website. I think that some of these questions are on the CLL website. So, there's some questions, that you can think about. There's one thing I would say to you all, if you're thinking about, your treatment, always ask, is there a clinical trial for me? Ask your clinician, is there a clinical trial for me? And be confident in trying to ask that question. What is it? What should you consider? What are the advantages and the disadvantages? So would you be a guinea pig? Absolutely not. Will you get a placebo? Absolutely not. What are your rights? And what if you want to quit the trial? Now, you saw I had to pull away from a trial, or you might want to quit. Well, that's fine. All that information is given to you at the very, very beginning by your wonderful nurses. And that one down there as well. By your wonderful nurses. Sorry, Darren, I haven't forgotten you. Yeah. Yeah. So I think, they're just, yeah, I'm ruining your image, aren't you? Darren. There's one thing my prof said to me when I was first diagnosed, and he said, I was part of this team. He meant the team, Jane, Darren, et al. That were there, Arvind and Nagesh, and that's what I really feel. I am part of that team. As Sister Gabriel said to me when I was in primary school, Moira, you've got the gift of the gab. Go around and tell everybody everything you need to know. But I really do feel part of my clinical team, and I have that confidence in being able to. I've been given that opportunity, and I've been given that confidence in being able to question and to counter. And I think that's also what you should be able to feel as well when you're going through something like this, that you are part of that team. And I think that's very important.
Oh, 10. Missed off one question. What's my cost? Yeah.
Very strange on that one, because sometimes I've spoken to people and they think, you have to pay on your clinical trial. No, there are no costs. There are no costs. It's not America. there are no costs.
And then questions for us. So thank you. Thanks everyone for listening.
That was absolutely fantastic. And Moira, you were talking about the wonderful nurses and the wonderful medical team that you were part of. I think we ought to say another thank you to the wonderful Moira. So we've got time for a few questions. Just one from, okay. There, okay.
Thank you so much, Moira, and your team, because the qualitative research that you've provided is just so personal and it's absolutely marvellous. I'm just interested to know, as part of a trial, and there are two parts to this question. One, the drug treatment has obviously developed so much, become more sophisticated, so we can actually skip the suffering, in inverted commas, is what you've undertaken. The second one is the COVID did intervene. Did you have any reactions to the COVID injections, please?
Should I take the second part of that question, and then I'll let Jane probably be better answering the first part. So the question was, did I have any issues in relation to COVID with the vaccine? When I got COVID, I'd only had one vaccine, and fortunately I'd had one. So, these, when you're on these drugs, and I think you had Stella speak before about them being BTK inhibitors, that's Bruton's tyrosine kinase inhibitors, and we know that, from what Stella said before, there's a lot more research going into why we didn't have as much strength, shall we say, from those vaccines. But I'd had one, and thank God I'd had that one. But I'm all right. I'm here to tell the tale. As 7 later, I've just had my 7th vaccine. So I just had that one, and hopefully, and I'd also been on steroids as well, so my middle science daughter said, Mum, I'm sure it's because you've also been on a lot of steroids, even though they give you dexamethasone for 3 days. I'd been on a course of steroids anyway because of my infection. So possibly, with the grace of God, but I'm still here to tell the tale.
You'll have to forgive me, I've forgotten the first question now. What was the first part of the question, sorry?
The first part of the question is the quantitative research that's been done. Moira's one of a number of trials, and because this is a clinical trial, I'm just interested to know the success rate and so on of the other patients.
I think I think we've put a lot of people. Clarity, we only had a few people in. I think we had quite a few people in Arctic. Assure, as it happens, Moira is the only person on the trial within our centre, but obviously all that collectively goes into a big data bank of the trials that run across. It is global, Assure, to be honest, whereas Arctic and I think Clarity we're only running this country, to be honest, but we hear feedback from them, and certainly they've all produced really good results. I think of its time, what came out of Arctic was the fact that maybe the mini-R didn't work so well, but at that time, FCR was still the best treatment and there wasn't anything better. But as we move things forward, certainly that combination with Bruton and venetoclax is an excellent combination. That's what we saw with everyone, really. It worked really well. And then obviously next generation acalabrutinib has worked equally well with less side effects, really. So it's a nice positive story all the way through, really.
Bruce, I think I was speaking to someone before who's on acalabrutinib, and it's so far so good. It's amazing. It is an amazing drug. Its other name is Calquence. Drugs have 2 names. So if you see Calquence is acalabrutinib, and it's just amazing. It really is. You still have to look after yourself. You still have to remember your body is like a mobile phone. One day you can get up and feel really charged, really ready to go for anything, and then You know, you go out there and then I just have to say to myself, whoa, stop. You know, sometimes you can do a bit too much. So you've still got, as Stella said in one of her slides, you've got to live healthily as best as you can. But you've also got to remember your body. You know, you've got to give your body a bit of slack as well. You know, don't go too mad if you're suddenly feeling absolutely super duper. Give yourself a bit of slack. But yeah, I think it's a brilliant job.
So just a final question here, and then we're going to go on to some roundtable groups. Oh, okay.
It was my belief, maybe wrongly, that people went on to clinical trials when all other options had failed. Am I to understand that you chose to go on as clinical trial rather than accept standard treatment?
My first clinical trial, I had no choice. Prof said to me, I've got a clinical trial open. I think it would be good for you to consider. And that's what I did then. But having had the experience of clinical trial, when my uninvited guest came back again, I wanted to go on to another clinical trial. We were very fortunate because then there was clarity.
I think sometimes that trials are a last ditch and it's what people do when there's nothing else. And there are those phase 1 trials we alluded to earlier. That's what phase 1 is. It's when perhaps you've exhausted all the other options and you still want to try something, and they're first in human trials, so potentially have more side effects and are a little bit unknown. But it isn't the case these days. A lot of the trials are looking at, okay, we've got a good standard treatment. Can we make it better by adding this drug in or tinkering with that combination or doing something a little bit different? So it's about driving the knowledge forward really nowadays, rather than you can only have this or nothing else kind of thing.